All right. Well, hello, everyone, and welcome to another session of Virtual Global Spine Conference. My name is Ali Baj, and I'm excited to be here today with some of our co-hosts and panelists, Dr. Mike Selby, Dr. John Shin, Dr. Mike Galgano. And we are exceptionally honored and excited to welcome our guest today, who is Dr. Amit Jain. Dr. Jain is an orthopedic spine surgeon at Johns Hopkins Department of Orthopedic Surgery. He completed both medical school and residency there, went on to do fellowship at Emory, and now and has come back to Johns Hopkins to have a pretty diverse and really exceptional practice in both adult and pediatric spine surgery. As some of you know, who if you follow some of his work, he really has been one of the leaders in taking a good look on how this pandemic has affected spine care at different levels, and he's well published on that as well. So we thought it would be timely to discuss this topic and bring him on board and seeing if he can share his findings with us and his thoughts on how COVID has not only how it has impacted all of us, every single person here, whether you're a participant, surgeon, student, faculty, we've all really have been affected by it. Thankfully, obviously, not to the serious degree as others who have succumbed to it. But we certainly know that from a practice perspective, a teaching, training perspective, we know that the effects will linger on for years to come. So without further ado, Amit, thank you so much for joining us and welcome to our program.
Thank you, Dr. Baj, and thank you to the distinguished panel for inviting me. My goal today is to discuss the impact of the pandemic on musculoskeletal and spine care, and hopefully get into a discussion with all of you about how this is affecting your daily lives and what we can do about it. No relevant disclosures. I do have some research funding from the NIH, which is not relevant here, as well as some consulting agreements, none of which are relevant. So the reality of the matter is that, unfortunately, we are approaching almost 1 million COVID-related deaths in the United States. Worldwide, it has really been a devastating phenomenon with over 7 to 13 million access deaths. These are people who unfortunately succumbed to many medical conditions, COVID and otherwise, as a result of the pandemic. And these numbers are only slated to increase over time. The pandemic has really had a ripple effect on healthcare at large. There have been delays in routine and preventative care. There has been cancellation of non-urgent surgeries and procedures. Certainly a lot of elective work that we do as spine surgeon has been affected. Here is an example of a 15-year-old boy with scoliosis who needed a posterior spinal fusion operation for correction. Unfortunately, his surgery was delayed over 6 months because we were cutting down on elective surgeries at our location. Here's an example of a 14-year-old girl with Sherman's kyphosis. Again, her curve actually progressed quite a bit during the waiting period. Her parents were afraid of keeping her in the hospital because of her special needs. And as a result, her surgery was delayed over a year. Here is an example of a 62-year-old with lumbar sagittal deformity who unfortunately needed a 3-column reconstruction and required an ICU bed, but we didn't have ICU beds available to take care of her. So we had to delay her surgery for several months as well. These are all examples of patients who suffered during the pandemic, among many others. And sometimes some of these surgeries were delayed because of patients' fears of coming to the hospital and interacting with the healthcare system. And sometimes these delays occurred because we were just simply closed. We didn't have the capacity or the ability to provide care, which was much needed. So our goal today is to really explore the impact of the pandemic on musculoskeletal and spine care. I hope to do that from 4 different lenses and would love to engage you in this discussion. So the first lens we'll look at is trends in ambulatory and inpatient care. Second, access to and disparities in healthcare. Third, economics and business of health. And then finally, I'd like to spend some time talking about mitigation strategies and how as surgeons we can be leaders and lead this. So let's start talking about ambulatory and hospital care. So once the pandemic became more well known, there was an immediate effect and there was a significant decline in ambulatory volumes, starting with 2020 early on, and then that kind of trailed off toward the end of the year. The area under the blue curve basically represents the cumulative deficit. So these were the ambulatory visits that should have taken place in 2020, but did not take place as a result of the pandemic. So these are patients who needed to see us for back pain, for back issues, neck issues, and so on, patients who, some of which required surgery, but unfortunately were delayed. If you add up all the numbers, including the cumulative deficits for each month, different specialties suffered differently. Orthopedics and musculoskeletal specialties generally fell about 20% below volume compared to historical years, so 16 to 20%, depending on the estimate. So certainly this would affect patients, this would affect practices. Interestingly, another phenomenon started happening. In addition to patients not seeking outpatient care, a lot of patients also stopped showing up to the hospital. And this is for not just emergency or elective procedures, but also for kind of what we think of as critical medical diagnoses. So here's a study that looking at a reduction in Veteran Affairs hospitals for emergency conditions. And during the pandemic, there was almost a 42% reduction in admissions for critical medical diagnoses for conditions such as stroke, MI, heart failure, COPD, pneumonia, etc. So as you can imagine, these patients were unfortunately suffering from these grave illnesses at home and not really coming to the hospital because of fear. A study looking at cardiac arrests found a similar reluctance among patients to seek care, and patients were afraid to even call 911 because they were afraid that they would be taken to the hospital and may contract COVID. So this fear of the pandemic resulted in lots of excess morbidity and mortality. If you look up all the numbers, essentially for 2020, despite of the additional admissions because of COVID, the total number of admissions were rather down for the year. And then as you can imagine, this would result in excess deaths. So from COVID and many other causes, there was a net 23% increase in all-cause mortality from March 2020 to January 2021. In other words, 1 in 4 deaths were because the pandemic occurred, and these were deaths not related directly to COVID, but really related to other conditions that could have been medically treated, but unfortunately were not as a result of the pandemic. And as you can imagine, this would have widening effects on social and health inequalities, and that's exactly, unfortunately, how it played out. So African Americans, as well as underserved historically groups, suffered from the brunt of pandemic and also suffered from increased hospitalizations and increased mortality and morbidity. And there are certainly many factors that go into this. We can discuss social determinants of health. We can talk about economic stability, social and community context, neighborhood and environment, access to healthcare, education, and certainly people's willingness and reluctance to get vaccination. All of these things can certainly play into it and affected patients' outcomes. So the key message for that first part is that there were early declines in ambulatory and inpatient visits, which not only affected patients' ability to seek care, but also kind of kept them away from the hospital due to access to services and fear, and resulted in excess morbidity and mortality, and really minority and poor communities were disproportionately affected. Now, keeping this framework in mind, I'm going to kind of transition toward how this impacted us in musculoskeletal service lines and orthopedic and spine care. So once the pandemic started, people started looking at what happened to overall type of care. So preventative care certainly dropped, as you can imagine. Services such as colonoscopy, mammograms, hemoglobin A1Cs, vaccinations for other non-COVID conditions all dropped. Non-elective care also took some hits. So things like angioplasty. Obviously, L&D did not take a hit because babies happen when they happen, or they come when they come. Musculoskeletal surgery, on the other hand, take a massive hit. So almost a 50% reduction, depending on the month looking at. And similarly, things like cataract surgery, which were more elective in nature, took a big hit. If you look from a service line and service volume perspective, a certain analysis by Strata Health demonstrated that spine and orthopedics were 2 of the top 4 service lines to take a big hit. So spine volumes were down 76% and orthopedic volumes were down 74% at the peak of the pandemic. But certainly some of these numbers bounced back up, and at some point we try to play catch up because of the backlog that this resulted in. We looked at this for the state of Maryland, and we looked at Maryland elective surgical volume and surgical admissions. And what we found is that compared to 2019, which is this checkered bar, in 2020, there was a pretty precipitous drop, from Q1 to Q2, and then a little bit of a bounce back in Q3. So in Q2, there was a 56% drop, and in Q3, there was a 16% drop. And the largest declines, not surprisingly, were in orthopedics, neurosurgery, urology, and plastic surgery. Many of ortho-neuro procedures being the elective spine procedures that we frequently use to take care of patients. And large drops in various service lines as demonstrated here in Q2, and then bouncing back in Q3 and Q4, coming back up. McKinsey et al., which is a large consulting firm, also looked at this phenomena, and they surveyed the 25 largest US health systems. These are systems with over 1,200 beds. And on average, what they found is that the hospitals saw about a 34% decrease in OR volume, so a pretty significant amount of decline, and started early in the pandemic around April and May time, and then kind of persisted over time and into 2021. And certainly the largest declines were in orthopedic surgery, ENT, and plastic surgery, the areas, orthopedic being the one we care about. Surgical volume losses were attributed to a variety of factors: workforce shortages, inpatient bed availability, OR room capacity, many of these things which we're still struggling with. Workforce shortage is really something that has continued to persist despite of the pandemic being going on for 3 years now. A lot of great migration of the nurses and so on. And these are practical issues we're dealing with on a daily basis and have been persistent with us since the beginning of the pandemic. As you can imagine, a lot of these cases that should have been done but were not performed would add to the backlog. So the backlog, according to the McKinsey report, was a combination of surgical backlog paired with reduced effective hospital capacity would impact both providers and patients for years to come. That was the conclusion they came up with. So we started thinking about, well, how is this going to impact waiting times? How is this going to impact backlog and patients' ability to seek care once things start opening up? And certainly in other health systems, such as the NHS, there's the concept of waiting lists, which in the United States historically wasn't so bad, but certainly has gotten worse recently. So we modeled ramp up and backlog in elective orthopedic surgery. And we thought this was an important topic, so we looked at this. So in order to do this, we thought about how can we think about when things start opening up and how long does that take? So we started looking at prior pandemics or prior epidemics. So we looked at the Asian flu and the Spanish flu. And if you look at prior data, basically the bounce back after the pandemic usually takes time. So in other words, it doesn't happen overnight. It's usually a slow sigmoidal function. So the recovery is sigmoidal and takes time. So we started with this premise and then decided to model what would happen to the volume of spinal fusions and joint arthroplasties in the United States over time. So our assumptions were that we can't go from 0 to 100 instantaneously. And then factors such as supply chain, as well as staffing shortages would certainly play a role, as well as the back and forth about openings and closures would play a role. We thought that the ramp up would be sigmoidal and use a Gompertz function with a Monte Carlo simulation technique to kind of model that. So for those who are not familiar, Monte Carlo is basically a technique to model uncertainty, which is frequently used in econometrics. And the idea is you repetitively kind of sample a probability distribution and come up with some estimates with some confidence intervals. So this is what the data look like. So prior to the pandemic, in the United States, across the country between ortho and neuro, we were doing about 170,000 spinal fusions plus joint arthroplasties each month. With the pandemic, there was a pretty precipitous drop to almost 5 to 10% range of that. And then we modeled what would happen starting July 2020, and then over time, what this would look like, depending on a variety of scenarios. The green representing the optimistic scenario where things would bounce back quickly. The yellow representing the ambivalent scenario where things would kind of take time and have a natural ebb and flow. And the red being pessimistic scenario where things really would continue to remain rather slow in terms of opening up. And what we found, interestingly, is that it would take, regardless of the health system's effort, it would take somewhere in the 16 to 20 month range to kind of get back to 90% of pre-pandemic volumes. And as you can imagine, there are really two types of backlog. There's the fixed backlog, which are cases not being done while the suspensions are taking place. So we estimated this to be about 500,000 cases. And then there's a dynamic backlog, which are cases not being done while you're not back to 100% production capacity. In other words, as long as you're not operating at your full capacity, you're adding to patients that could have been taken care of, but are not being taken care of. And this continues until the ramp up is complete, and certainly also affected by future slowdowns. And that's unfortunately been the reality. So if you add up all the backlog and kind of run the simulation with the fixed backlog and the dynamic backlog, our results basically concluded that there would be close to 1 million cumulative backlog of surgical cases. This represents joint arthroplasties and spinal fusions that should have been done, but need to be done and haven't yet. So the key message is orthopedic surgery was one of the worst fields hit by surgical and procedural suspensions. And I use the word orthopedic broadly to include a lot of our neurosurgical colleagues in their procedures for spinal fusions, and likely created a large backlog, over 1 million cases in spine surgery and elective arthroplasty. And implications for disease progression and increased severity are certainly there. Now I would like to talk a little bit about the effect of all of this on access, revenue, and then from the perspective of both employment and insurance, as well as hospital revenue.
Yeah, Amit,
So-
can I ask you a couple of questions on the previous section? Thanks for going through that. That was
Absolutely.
very thoughtful. So, so you modeled this, right? But now we are in February 2022. So what are the actual numbers? Is your model accurate? Did we catch up? Did you guys catch up? How did the reality kind of
Yeah, no,
relate to the model? Because what I was thinking as you were going through this, because we all said the same thing, right? When things quote unquote open up again, we're going to catch up very quickly because patients want to get in, they want to get the surgeries done. Well, what we didn't really, I don't think many people thought about was, well, we were not going to have the staff to do it. We're not going to have the OR time to do it, the resources, not to mention, we probably didn't get that influx of patients who all of a sudden, we're waiting for 2 years. So I have a feeling that although many colleagues are getting busy again, I'm not sure we got there. What do you think? What do your real numbers tell you versus?
Yeah, no, that's an excellent question. It's something I think about all the time, because at that time, this was just a back of the envelope kind of prediction that we made up. So I actually got invited to lay down our own health system data on top of it. And interestingly, I don't include that here, but we created a similar kind of prediction for our own health system, and we actually fell on the orange curve. And depending on the department, departments like ophthalmology fell on the green curve because they were outpatient and could do a lot of procedures in the outpatient setting where patients weren't being affected from our inpatient bed shortages. But departments like neurosurgery and orthopedics fell more toward the orange to red curves, depending on the specific procedure chosen. And a lot of our, I think what that really did is it also spurred changes in practice. So for example, a lot of our arthroplasty colleagues moved their practices from primarily hospital-based to outpatient ASC or HOPD-based, where they would do joints in an outpatient setting, and really kind of spurred that moment. And in our own spine cases, we started moving a lot of our cases toward doing them either in an ASC setting or in an outpatient setting. So cases like ACDF, et cetera, which we would historically keep in the hospital, we started sending patients home with a drain and so on. So it certainly spurred a lot of that interesting work, which I'll share later as well. But the reality is, depending on your institution, you can fall into one of these three curves. But I don't know of anybody who went from 0 to 100, within a month or within 2 months, because of all these other factors like supply chain and staffing that we didn't predict.
Great, no, thanks. That's very helpful. I want to ask one of our panelists, Dr. Selby. Mike Selby is an orthopedic spine surgeon in Australia, also very in tune with the impact of the pandemic on spine care, at least in that part of the world. Mike, what are the numbers? Maybe on just on a big scale, on a large scale, how do they compare to what Amit is showing in terms of this model? I know there have been several, stop points and checkpoints, and we take one step forward, 2 steps back. But how many months or years do you expect it's going to take in, say, Australia to kind of catch up and be where you think you ought to be?
Yeah, Australia is a bit unique in that our system is a real mix of US, so mainly private-based medicine, and the UK or Canada, where you've got public. And it's about 50-50, although about 70% of our overall elective surgeries, and I don't like that term, I mean, they're necessary surgeries, just not urgent, are carried out in the private sector. So we've already got our sort of public sector patients behind. And we've ended up with, we're going to end up with massive waits, particularly in the public sector. Now, our private sector does have the ability to sort of flex up a lot. A lot of our private hospitals are not completely full. And so, and that was even before the pandemic. And so we do have some ability to recover that. We are looking at pretty similar numbers per capita, I believe, of being behind in surgery. We do have whole states that for the last 2 months have, since we had Omicron out, have only done cancer surgery as non-urgent emergency surgery. And so every arthroplasty, every spine fusion, every ACDF without a deficit is waiting. Some areas kept powering through, and so we're highly variable. but it's just fascinating data. I mean, our death rate has not been as high through the first sort of 18 months or so of the pandemic, but we're catching up now in terms of per capita death rates as well. So look, I think where we're going to see the biggest effect is in public health and our public patients. And, I think Canada and the UK are going to be really affected by this because the lack of private medicine. It's going to be interesting to see how they handle it.
Yeah. Thank you for that, Mike. Good points. Amit, sorry to interrupt. Please go ahead.
No, that's an excellent perspective because it's always interesting to hear about colleagues from around the world and how they're dealing with the same challenges. So, thank you for sharing that. That's wonderful. Let me just talk a little bit about access revenue, and then I think the area I would love to spend a lot of time about and hear the group's opinion is mitigation strategies, because I think that's an area where all of us, I'm sure, have unique strategies we're employing, and I would love to hear people's thoughts and have a cross-cultural collaboration about what we can do about this. So as you can imagine, the pandemic also spurred a large unemployment problem. And the reason is a lot of service industry really was unemployed all of a sudden. So as you can imagine, unemployment fuels insurance losses. So if you don't have a job, you don't have insurance, because in the United States, a lot of insurance comes from people's jobs. So 26 million additional people were newly uninsured as a result of employer-sponsored insurance loss. Some of these people went into Medicaid or government programs that basically try to absorb through Obamacare expansion some of these patients. So this is data, interestingly, from 2021, and you can see Medicaid expansion has been record high. We're adding 10 to 12 million new Medicaid people every month into the program. So it's the highest it has ever been. And certainly some of these coverage gaps still exist because not all states decided to expand and have the ACA Medicaid expansion. So some of these states continue to struggle, and those patients don't have insurance. In addition to insurance, the other factor is out-of-pocket payments. Because in the United States, we have a system where not only insurance is important, but you also have a out-of-pocket payment that you have to make as part of your surgery. So as you can imagine, inflation has been all-time high. And as a result, out-of-pocket payments increase, which also has an impact on your ability to seek care and seek surgery. We looked at this. We looked at both out-of-pocket payments pre-ACA, pre-Obamacare, post-ACA in setting of Obamacare. Interestingly, what we found is that in setting of the ACA, the out-of-pocket payments continue to increase, but the growth was slower. And then we have some work coming out in a JAMA network that also looks at what happened to that during the pandemic. But this was some of the pre-pandemic data. So the key messages were that unemployment spurred insurance losses, and there were large shifts in insurance from employer-sponsored to state federal program for low-income or unemployed patients. And then more uninsured patients means you have less ability to seek care or less ability to get the surgery that you need. So really increases suffrage. Next, I'll talk a little bit about practice in hospitals. So as you can imagine, the pandemic resulted in a lot of private practices and kind of individual solo practices to close down. There were really unexpected winners, for the lack of a better word. And some of these winners were insurance companies. So premiums were being paid, but they were not being paid out to consume claims. So in other words, United Healthcare, Anthem, Humana, et cetera, saw record profits. And if you were to purchase United Healthcare stock in the year 2010 and or hold it now, you would do rather very well. And that trend has continued during the pandemic. Similarly, primary care practices suffered huge losses. So estimated $15 billion revenue loss for PCP practices in the year 2020 and 2021. The AMA, which is the American Medical Association, surveyed physician practices and found that most practices actually found some revenue loss, on average about 30% net loss in revenue. And this is across different specialties. In addition to physician practices, hospitals saw huge losses. So depending on the hospital system you look at and the strength of the system, there were projected losses of about $320 billion according to the AHA. The actual data is always hard to get because of CARES Act money, et cetera. And I'll show some profit statements about how that kind of played out. But here is kind of more realistic data. So this is hospital and health system margins based on real data. So CARES Act were the bailout money. So despite of the bailout money, hospitals were still in the red on average across 2020 and most of 2021, losing about 2%. in the red. So pretty significant amount of losses for the hospitals. Here is another assessment of hospital margin impact, resulted in over $92 billion losses without CARES Act money and $54 billion losses across the country with CARES Act money. And why is this? Well, three reasons. Number one, now you have sicker patients who are in the hospital. So these are COVID and other related illnesses. You have higher expenses. You have to pay for a lot of nursing shortages through and backfill that with travelers and other kind of higher expense individuals. And then you have fewer outpatient services. So a lot of your patients who would seek care in outpatient are not seeking care, and services such as colonoscopies and such, which used to be kind of the cash cows for the hospitals, were really suffering. So you got a double whammy. Now you're taking care of a sicker population, but then on the outpatient side, not making revenue on kind of the healthy outpatient patients. So interestingly, they were not all losers. There were some winners in this process. Big hospital chains started buying up competitors, and some interesting work by Reed Evelson and others you can read about. Maryland is a unique state. So that's the state where we're based in, where Johns Hopkins is. Maryland has what's called an all-payer system, which is very unique in the United States. So Maryland has had exemption from our federal government for many years, since the 1970s, to have a unique healthcare structure where prices are set by a common body called the HSCRC. And all payers, regardless of what you are, Medicare, Medicaid, Blue Cross Blue Shield, et cetera, all pay hospitals the same rate. And essentially what that means is if you have a central body setting prices and it's not through negotiation, then the central body can up or down regulate prices based on their interests. So during COVID, they actually allowed hospitals to increase prices by 10 to 20%. And we actually looked at this, and we're fortunate to publish this in JAMA. And what we found is that in Maryland, hospitals actually made money, or at least broke even by the end of the pandemic, and did not lose any money because of the HSCRC action. So the HSCRC prices increased buffered hospital revenue losses. So the actual loss would have been what the orange line is, and then what the dotted line is what the loss would have been had the HSCRC not stepped in, and the orange was how the losses actually played out. And the delta between these two curves is basically the net positive or negative, and the hospitals actually came out on the top at the end. So the key message here is that physician practices lost significant revenue. Many hospitals struggled as a result of the pandemic. Hospitals in states like Maryland really fared well because of unique financial models, which shifted some of the risk from the payer to.
Amit, I'm sorry to interrupt. That last slide got my attention. Can I ask you a couple of questions on that?
Yeah, absolutely.
Obviously, you're very familiar with this. It's your paper and it's Maryland data. So the contention here is that the Maryland hospitals more or less kind of either did not suffer the same losses, or in some cases actually made profits. Is that right?
Yeah, I think I would say their losses were buffered by the state intervention.
And the state intervention allowed them to increase their charges and their collections, and that's why they were able to buffer that. Who paid for that? Are these private insurance? Are these private payers, or is this federal? Are these federal payers?
Yeah, interestingly, because it has an all-payer system, all payers pay the same. So, for instance, if the price increases for Medicare, the same price increases for private payers as well. So everybody kind of contributed to the hospital losses.
And one last question: did the private payers in your state, because they had to say incur additional losses, if you will, or had to pay out a little bit more, did that in turn get pushed over to policyholders and folks who are paying insurance in your state?
Yeah, that's a really great question, Ali. I don't know the answer, and something I'm actually actively working on trying to figure out. It's sometimes hard to look at the direct impact on actual policyholders, because some of that data is a bit murky and but I think in a couple of years we should be able to tell once a lot of it comes out as far as historically what happened and whether that was pushed onto the patients. Because that's a great point.
Got it. Great. Thanks so much. Yeah, these last few slides just got my attention. I don't know if what other people think, or John obviously works at a major health system in Boston, and Mike is in upstate New York. But the question is, it seems to me from the last few slides that you showed, is that there are certain medical centers and facilities, if they're probably a little bit more adept and in better position to navigate these issues, in terms of the financial issues from COVID. I don't want to say some were smarter than others, or some were just, I don't know how they did it. But John, what do you think up in the system where you're at? Are you aware of, just in big terms, obviously you don't have access to the granular data, but were some of the Boston hospitals or medical centers able to utilize and leverage some of these tricks and techniques to offset some of the losses from COVID?
Yeah, I'm not really sure about that, to be frank. I think that it's a pretty complicated system, especially with the introduction of value-based care, and how that plays into a lot of these regional contracts, governmental payers. Honestly, it's kind of, this is not really my expertise, so I can't really give any insight in regards to that, but I know that the capacity constraints and I think the limitations have continued to be an issue for us here.
Great, thanks for that. Yeah, it is a complex topic. It's just one that I think, Amit, I love that you kind of dived into it, and I think it's good that you took the the onus on you to understand it better, because you're right. A lot of times we're left out and we don't understand how that stuff works around us. And honestly, the thing that impacts a lot of us here is what you mentioned regarding ASCs, right? So, some of the volume, some of the cases going to ASCs. I don't know. Listen, I work for a hospital. I'm a big believer in the big health system thing. I'm into that, but I really do worry that a lot of the spine volume will be shut off to the ASCs, and it will make these systems suffer even more. Amit, can you just comment on that a little bit more about what you think? Do you think that's just a one-way street and it's just never coming back? And are we just, even obviously as surgeons, should we just be ready to do more cases in ASCs, or is it still going to be just a different type of demographic, different types of surgeons, doctors who are going to go that way? And I know ASCs is a big topic, but just
no, that's a fascinating area, and I would love to. I feel like you're setting me up for my next section, which is the mitigation strategy. So this is the perfect segue. Can I just request we maybe just pin that question for a minute, and then we'll come right back to it in about 5 minutes. Okay. So let's, I think this is probably my favorite area, and I would love to hear everyone's insights about mitigation strategies. So, okay, so this COVID is there, the pandemic is here. It's been going on for 3 years. All of us have COVID fatigue. We are tired of this. We are sick of this. We just kind of want to do our job and take care of patients. So what can we do? So here are some mitigation strategies that we thought about early on in the pandemic, and wrote about and published on this in Harvard Business Review about how can we get back on track, and what can we do about this. And some of these have been very successful, and some of them not so successful. So one way we thought we should attack this issue is preserve access to care. So one way to really get to patients and really address their needs without necessarily putting them at harm's way by having them come into the hospital or necessarily playing out their fears, at least in the pre-vaccination era, was through telemedicine. Now, obviously, things are a lot safer, but the point I'm trying to make is that one of the key things that kept patients away from the hospital was their fear of contracting COVID. So if we can continue to care for them at a convenience of their home, that's a great way to do that. So preserving access to care through telemedicine and patient engagement and fear reduction. Here's the data for our department for orthopedic surgery for each week. And as you can see, we were doing several thousand telemedicine visits each week. And then here's our data for all of Johns Hopkins. So neurosurgery, orthopedics, urology, transplant. I mean, we moved a lot of our surgical departments into telemedicine champions, and really benefited us hugely. Secondly, transition to outpatient care. Dr. Baj really brought this up, and I think it's an excellent point to discuss. Patients like outpatient care. Patients like having surgery in an ASC setting for the appropriately selected case. Overall patient safety ratings for ASCs is excellent or very good. 77% of ASCs are multi-specialty, including spine and orthopedics and so on. And many of the ASCs are actually pretty well equipped with multiple rooms or capacity to take care of patients for both basic and somewhat, I would say, medium complexity conditions in spine. So I think a lot of our care, we started transitioning to the ASC setting. To answer Ali's question, we started doing cases like ACDFs, lumbar decompressions, and so on in the ASC setting. Now, obviously, a lot of that has to be a thoughtful decision. It has to be appropriate patient selection. It has to be there has to be systems set up about what do you do when things don't work out in the ASC, what's the backup system, what are the patient preoperative education mechanisms, postoperative follow-up mechanisms, and so on. But I think with appropriate mechanisms in place, ASC can be a very good environment. And in fact, Johns Hopkins Hospital opened one of the largest ASCs in the country in the middle of the pandemic. And they were afraid whether it's going to work out or not. And it's booming because patients really enjoy that location to seek their care. So I think, Ali brought up a great point about do hospitals, shoot themselves in the foot by opening up ASCs? And the answer is maybe not. Maybe coming up with some clever ways to do physician hospital joint agreements to really ensure success of ASCs can be a way forward.
And Amit, thanks for answering that. Do you recommend, based on not just your practice as a spine surgeon, but somebody who's has been very involved in understanding how this pandemic has affected your health system? I mean, hopefully we won't get another one right for 100 years or even more. But do you recommend that other surgeons consider, again, in a safe environment where you can provide safe and quality care? Do you recommend more spine surgeons, whether neuro or ortho, get involved more with ASCs in terms of operating there, trying to do cases there, if your current employment contract allows? I've always been a little bit, I guess I didn't know enough about it until the last few years, where it's just coming up a lot. And a lot of the cases that I do and that you do are just not appropriate for ASCs. But do you think, would your advice to younger surgeons or even more veteran surgeons to consider getting a little bit more comfortable in the ASC setting, because that trend will probably continue?
I think so. And I think one way to do that is, even if you don't have access to an ASC or don't want to go there, you can start simplifying your own practice. So in other words, trying to figure out what can you do in your own practice in terms of preoperative counseling, postoperative care mechanisms that can get patients out of the hospital faster. And if you can do that more and more efficiently, even within a hospital setting, you can then kind of make that transition safely as opposed to trying to force it. And I think for me, the pandemic really allowed me to do that. It allowed me to think about ways we can create better safety nets for patients and allow them to give them the comfort of saying, okay, you don't need to stay in the hospital 2 nights. It's okay to go home the next day, or it's okay to be able to be cared for in an outpatient setting, and so on.
Got it. Thank you. Alex, I want to ask Dr. Mamagani. Amit, Alex is our point person in Europe. He's an orthopedic spine surgeon in Switzerland, and one of our panelists. And it's always either midnight or 1 a.m. there, and he's always with us. And here he is again. Alex, what do you guys have ASCs in your neck of the woods, and do you utilize them? Do you work there? What are your thoughts on ASCs there, and especially now during the pandemic?
Yeah, hello, great talk, Amit. I love these data, and I love this presentation very much. Yes, ASCs, we have this, and we have a shift towards to ASC. So when COVID hit us, I was preparing the start of endoscopy. I was starting ASC, but then everything changed, and the staff was deployed to ICU, was deployed to everywhere else, and so any ASC project was ruined by COVID, start of COVID in March 2020. And now this is a big run to ASC, and we started successfully doing endoscopy, and I think this is the future. And I use fusion techniques that allow ASC fusion surgeries as well in ASC. But everything is completely different in Switzerland. We are a small country. We have a very expensive healthcare system. So now it's completely different than 2 years ago. But we have a trend towards to ASC. It's a little bit a question of generation. The 60 years old head of departments won't really forcing to go into ASC, but the younger generation will have to do this step. I think if you want to grow, if your department wants to grow, there is no other way than to go into the ASC, because our hospital, the capacities are full. We can't grow there a lot.
Yeah, that's a really wonderful insight. So it's always interesting to hear about our European colleagues and the kind of the unique challenges that they face. And
Right. Although Alex, off the record and offline, I want to know more about what's an ASC fusion procedure, but we'll leave that offline.
So my first talk on virtual spine conference was about this cortical bone trajectory, small incision, less blood loss. When these patients get up a little bit earlier than the MIS TLIF or the open ones. And I know from many centers, they look for those techniques like MIS. I don't think that when you do a proper patient selection, that you will be able to do this with an open, classic TLIF procedure like I learned 20 years ago. I think you won't be able to do outpatient fusion surgery very successfully. Maybe it's possible, but only in 40 years old patients who really are coping very well with pain. But my standard patient, I think he will not accept this fusion. So another technique brings the opportunity to do it ambulatory.
Absolutely, makes perfect sense. Thanks for that, Alex. Amit, I'm sorry, I'm taking a lot of your time, so I apologize for that, but I really want to get the insight from some of our panelists. I'm going to go to Mike Selby. I know he's got something important to say, but then after that, I do want to ask Nader and Michael what their thoughts on transitioning some cases to ASCs within their system and how that is playing a role or not playing a role in their current and future practice. But Mike, what's on your mind?
Well, look, I just actually wanted to ask all of the US-based surgeons, Ali, Amit, John, Mike, and Nadir, on sort of behalf of not just myself, where we keep our ACDFs for 3 days because our private health funds that. And so if we let them go too early, our hospitals don't get paid enough. I mean, how backwards is that, right? But then in Japan, they do similar things. They keep a laminoplasty there for 2 weeks in the hospital. It's routine. So there's all these cultural differences in surgery around the world. I'd just love to know, because we're actually moving more towards, that type of model of getting people out quicker in Australia. And how, at a practical level, like how do you do an ACDF through an ASC in terms of, do you have someone coming in their home the following day to check up on them? Do you have nurses that just sort of come by and give them medication, make sure they're not dead from a hematoma? I know that's pretty rare, right? But how at a practical level do you do it? Because I think a lot of the international audience that watch this are always amazed when they see US surgeons doing outpatient, say ACDF through the ASC.
Any takers on that, Mike or Amit?
Yeah, no, I think some of it is patient education and kind of prepping them appropriately. So it's the way I think about it, it's the way we teach our residents, right? You don't have a first-year resident, do a PSO. You kind of have to walk them through the thought processes, and you have to walk them through the indications and walk them through the training steps and the baby steps that it takes and so on, right? So I think for patients too, if you send the message that for the appropriately selected patient, you send the message that outpatient ACDF is a perfectly reasonable thing, and we're going to take all the precautions and safeguards in place to make sure that it's a safe and comfortable experience for you. Many patients will say, okay, I would rather be at home. So in my own practice, for instance, the dreaded complication is, of course, the hematoma. So I send them home with the drain, believe it or not, and they pull the drain on their own on post-op day 1. And I call them on the phone. I walk them through the instructions, and we have already practiced this ahead of time. Step 1, open the canister, Step 2, undo the dressing. Step 3, start coughing. And step 4, pull the drain. And I have never had a patient who has not been able to do this. It makes me feel makes me feel comfortable at night, and I can get a good night's sleep knowing my patient is safe with the drain and they're not going to have a hematoma. But do they need the drain? I'm not totally sure, but it's my safety mechanism. And we have a nurse and we have a physician assistant who calls them, day 2 and day 3 and so on. So you have to set up the appropriate mechanisms in place. But I think the point I'm trying to say is there's always a learning curve. And I think having patients appropriately prepped and putting mechanisms in place can allow safe innovation.
That's awesome, Amit. I tell you, I tend to think that I'm kind of well informed and I know a lot about a lot of things and all that. And you just proved me wrong, because I never in my life imagined that I can send home a patient with a drain and have them take it. I would never be able to convince my patients to do that. They'll be like,
but why not? Why not? The plastic surgeons do it all the time. The plastic surgeons send people home for drains for months.
I think that's ingenious, but I've never heard that one before, where you walk them through taking out the drain. That is absolutely awesome.
And I think kudos to Dan Rue. That's who I learned that from. Dan Rue sends his patients home with a Penrose drain, and he's a cervical guru. And when they take their dressing off, the Penrose falls out.
Wow, that's a good one. That's a new one for me. But Mike, I agree with Amit, and to that point about ACDF. So yes, it is. It's culture dependent. It's payer dependent. I would say there are folks who have published on this, who have done hundreds and hundreds and thousands of outpatient ACDFs and do great. I would say the vast majority of folks probably are still a little bit more conservative, and they probably keep the patients in the hospital overnight. But it's very rare, unless a patient's having significant issues, it's actually very rare to have the patient stay more than one night. Because again, it goes back in part to the payer. So your payers won't pay the hospitals if they leave home within 3 days. Our hospitals don't make money if the patient stays more than a day. So it's all over the place, unfortunately. But Amit, so do I have a second to just involve Nader here? Dr. Dadale, you probably know Nader very well. He's our neurospine surgeon, of course, at Northwestern, and also the program director. Nader, welcome. It looks like you're either in the OR or just got out of the OR.
No, I just finished and I was like catching up. And Amit, supreme talk. I mean, this is an important talk, and congratulations on publishing in Harvard Business Review, which a journal I really enjoy reading. I learned so much from it. I always buy it when I'm traveling, and have a bunch of the, those small collections, the summaries like on emotional intelligence and collaborations and what have you. It's really invaluable, topics that they put together. So, at Northwestern, we have an ASC, and, the orthopedic surgeons are the ones who really use it the most. And the advantages were definitely more pronounced during the pandemic because, there were, as long as you're doing outpatient surgery, you just can do the surgery. You don't have, as long as we're not admitting patients and there's room to accommodate patients with COVID, then you can still proceed with your outpatient surgery. So they really did not slow down much, them and urology. Now, in my practice, and as Amit touched upon, I send my patients the same day home after minimal invasive decompressions, 1 or 2 levels. Our ACDFs stay overnight. I'm comfortable keeping them overnight. 1 and 2 levels, I don't use a drain usually. So they'll stay overnight. So less than 24-hour stay, they call it. So it's kind of considered outpatient. But more and more spine surgeons are using, are trending towards using the ASC, especially for like single level decompressions, even 1 level TLIF sometimes, and then ACDFs. The advantage of the ASC too, in the surgery center, is the efficiency. So room turnover, they make it a point, like room turnover 20 minutes as opposed to the main hospital, it's about 40 minutes. So yeah, I mean, Amit really brought up a really important point. Like, you got to get comfortable with it. You start using it in your hospital. Discharge these patients the same day that you think are amenable to being well taken care of under supervision at home, and you get more comfortable with it. And then slowly you can transition to doing outpatient surgeries. I think it's important. It's something that with minimum invasive techniques and less blood loss, better patient populations, you can definitely capitalize on that opportunity. I personally, I work at the main hospital, and then the ASC is just a skywalk away from us. But I usually have like a small case and a big case, so I end up staying at the NMH at the same location, as opposed to doing a case at the ASC, then go back to the main hospital to do another one.
Thanks, Nader, for that. Any other comments before we give Amit his time back? Sorry, Amit, we kind of got into your time a little bit.
No, I really enjoyed that. I think those are great comments, and I totally agree with that comment. About kind of building up your learning curve before you want to. It's like reps. You just got to have the right repetition in a safe environment before you go do it in an environment you don't feel comfortable.
The reason is if you get a complication, then you would, you become really reluctant, like you had a hematoma or something like that, then you would take a step back and admit all patients. But, that's the thing, you got to be really meticulous about hemostasis and watch them a few hours before they go home, and then that'll be okay.
Then I think the other important points are, self-evident to us. Dedicated teams improve efficiency. This is something we know in spine care. If you have people who know how to work well with you and you cultivate them, they really help improve the care for the patients we take care of. The other important topic, which I think really came forward in the pandemic, is consistent, transparent, and bias-aware approaches for surgical prioritization. And Mike brought this up earlier. What's elective? Who decides what's elective? Elective doesn't mean unnecessary; just means not urgent. And whether you come up with a reserve system or a point system to come up with how you're going to prioritize elective surgery. So we thought about this a lot, and we developed a kind of a prioritization mechanism, an ethical framework, what we call, as far as deciding how to prioritize elective surgeries. And it's basically a multi-criterion decision analysis where you think about multiple values. You think about patients' values, surgeons' values, health systems' values, and you simultaneously optimize them. And the idea is it really is a difficult task. So I think in conclusion, the pandemic resulted in unanticipated damages to health and healthcare at large. There were large declines in treatment for musculoskeletal and spine conditions, excess morbidity and mortality, loss of physician and practice revenue, macroeconomic shifts and loss of insurance, and disproportionately impacted health of minorities and patients who were underserved historically. And certainly for orthopedics, musculoskeletal care, and spine care, orthopedics and neurosurgical care, there were backlogs that developed. And it's our job as physicians and as leaders to think about how are we going to address these, and whether that means making transitions in our care settings, whether it means adopting new strategies or thinking about other ways to address the long-term implications. So really, I'm going to open it up for questions here, but I would love for any of you to ever come visit us in Baltimore at Hopkins. And this is the view of Baltimore. So Ali can probably relate to this.
Thank you so much, Amit. Really nice discussion. That's just critical, and I think it's going. These issues and these topics and concerns that you brought up are going to be with us for a while. There's no question about that. And I was about to put in the chat box, one of your last slides was about the dedicated teams, right? The dedicated teams. We've known this for a long time. It improves efficiency in the OR. You get through cases quickly, safely. And I think I was thinking the other day that, all of the negative ways that COVID has impacted spine care, I call it really dismantling our dedicated teams because of the staff shortages, changes in, circulators, scrub techs, anesthesiologists, maybe not at a lot of centers, but, certainly at some medical centers with all the traveling nurses and just the dynamics that COVID has caused. I think in some ways, those dedicated teams that we were so used to are just not like they were, and hopefully we'll be able to come back to that. But I think dismantling of some of the dedicated teams in ORs and major tertiary urban medical centers is a real thing. But thank you so much. We've got some great insight from some of the audience, and as well as the panelists here. Any final thoughts or questions or insight from the panelists or hosts?
Amit, may I ask you a question? Here in Switzerland, we learned that those hospitals who were good before the pandemic did better during the pandemic. So a good health economic in your hospital, a good a financial admin in your hospital was really the key to survive the COVID pandemic. Do you see the same in your data? Could you be able to analyze how was the situation before? Was this good to have a good backbone of the hospital and the financial sectors?
Yeah, I think this is a very good comment, Alex. My theory about this is success breeds success. So people who were good to begin with were people who were savvy and adaptable and thought about a lot of these questions, maybe not in the setting of a pandemic, but at least knew about ways to navigate and shift resources around as appropriate to allow patient care to continue. I think people who really struggled, certainly the pandemic nobody predicted, but a lot of places that really struggled, were really caught off guard and didn't think or thought it was going to be just a temporary thing, or thought it was just going to be a minor inconvenience that's going to blow over in a month or 2 months or whatever. And that did not turn out to be the case. So it also goes to the point about how much our ability to take care of patients really depends on the infrastructure of things you can't control, like supply chain and nursing shortages and so on. So things, you might have the physicians there, but if you don't have the tools that you need to do your job because there's a shipment that's stuck across the world, you can't do it. So lots of cards here, but I totally agree with your point, and I'm not sure if I have the answer. I think in the state of Maryland, we were very lucky that we had the supply chain issues sorted out, and we had a financial model that allowed us to thrive. But not everybody suffered the same fate.
Great, thank you. Well, thanks so much, Amit. That was really very insightful, and it was some great information. And again, congratulations on the publications and the research that you've done. And we're looking forward to hopefully seeing some more of that work. And as we try to better understand how we're going to cope with this in the upcoming months and years. So thanks very much, Amit, for joining our program. We are back next Thursday. Dr. John Shin is hosting next week. John, any sneak preview of what we're expecting next week?
Yeah, sure. Hey, Amit, that was really great. And I just want to echo what Ali said. I think it's great to have a surgical colleague who is really an expert in leading out in this domain. I think this is very easy for policymakers and administrators to drive the conversation. So I think that for anyone who's in the audience, I would urge you to reach out to Amit. I think if you have specific interest, because I think there's a lot of potential for collaboration and even more research in this regard. So for next week, happy to see everyone next week. I'm going to share with you some of our early experiences using augmented reality in the operating room for spine surgery, sort of with and beyond screw placement. So looking forward to sharing some highlights, some videos and cases, and getting discussion in. So thanks, everyone.
Thank you so much for having me. Great.
Great. Wonderful. See everybody next week. Take care.